Hello, my name is Dr. Lejla Hadzikadic-Gusic, and I am a breast surgical oncologist at the Levine Cancer Institute and Atrium Health in Charlotte, North Carolina. It is my distinct pleasure to be here with you to give this talk, and thank you to the organizers of the conference for inviting me. I wish I was with you in person. Today, I will be speaking on breast cancer management in Bosnia and Herzegovina, which is where I'm from. Where are we and where we want to be? The problem is that breast cancer is the most commonly diagnosed breast cancer in women and accounts for 1 in 4 cases of cancer annually. An estimated 21% of breast cancer cases in Europe occurs in women under 50 years of age. In the United States, that estimate is about 7% under the age of 40. In Europe, 35% of breast cancer occurs in women 50 to 64 years of age, and the rest in postmenopausal women. According to estimates from the European Cancer Information System, by 2040, the number of women diagnosed with breast cancer will rise to 9.7% and the mortality to almost 25%. Therefore, it's certainly a topic of significance. The data on incidence and mortality in Europe is listed to the left on the slide, with 111 women getting this diagnosis. According to the Global Cancer Observatory in the Balkans, in 2020, there were 38,000 cases of diagnosed breast cancer and 12,660 cases of death as a result of this. The data on incidence and mortality of breast cancer in the Balkans here is listed in 2020, and these slides are courtesy of the Mosaic Foundation. As you can see, Bosnia and Herzegovina is listed at the top with the mortality in blue and the incidence in pink. The rest of the countries and the Balkan region are listed there. The one issue I want to bring up with this slide is that Bosnia and Herzegovina does not have a central registry. Therefore, it is difficult to ascertain whether these are accurate numbers, and it's my suspicion that these numbers are likely greater than you see here, but that we don't have an accurate estimate of them. Why is this important anyway? Why are we talking about it? Well, breast cancer is the most common cancer and most common cause of death in women across the globe. It's estimated that in Europe, it comprises 13.3% of new cancer diagnoses, making it the most common malignant disease. In the Southern Balkan region, there's no single comprehensive center for the multidisciplinary care of treatment of breast cancer. Hospitals in Bosnia do not have a standardized protocol, and as I mentioned before, there is no central registry of data for cancer. Therefore, it's very challenging to come up with numbers and find solutions to a problem where there's not accurate data to start from. The present institutions treating breast cancer in the Balkans are listed below, from Slovenia, Croatia, and two in Bosnia. What are we missing? Well, a regional center for the treatment of breast cancer, something that would have from diagnostic imaging to treatment, genetic testing, the capability for counseling, a multidisciplinary team approach with representation from surgical oncology, radiation oncology, medical oncology, certainly a central registry, coordination with hospitals for operative management and inpatient care, and research efforts to advance the understanding and cancer outcomes. The ultimate accreditation goal would be NAPBC and American College of Surgeons Committee on Cancer accreditation, which not any one of the centers currently in the Balkans holds. This would ensure that standards of care would be upheld to the highest level that we presently know. There would also be cooperative agreements with hospitals in Bosnia, which is incredibly important. Memorandums of understanding would be obtained with regional hospitals for operative and inpatient care. The process of establishing the MOU agreement means that there is a system by which you hold up the standards of care to these hospitals to participate with such a regional center. This would ensure then that these standard of care guidelines are being passed down to patients. Certainly, establishing connections with medical schools for advancing education of students and residents is an optimal goal, and connecting the regional breast cancer center with healthcare within the Bosnian healthcare system. Also establishing a clinical trials office and a research division to help start with identifying where the problems lie and where investments need to be made. Patient services that might be offered in a center like this would be diagnostic imaging from MRIs, mammograms, tomosynthesis, everything that you see here, to biopsies, clip placements, tumor localization, genetic testing, and lab work. I do want to point out that I will mention again in another slide that I separate mammogram and tomosynthesis in these slides, as not all places in Bosnia and Herzegovina have the capacity and access to tomosynthesis. Therefore, at least starting with the mammogram would be recommended. Procedures that one might want to see in such a center would be the ability to perform core needle biopsies prior to any operative intervention, so that you know what type of operation would best serve the patient. There are times that fine needle aspirations are acceptable. Radiation therapy would be delivered there, chemotherapy, immunotherapy, and port placement. Post-treatment care would also be offered there, from surgical follow-up, radiation therapy follow-up, medical oncology follow-up, and survivorship programs for women who have completed treatment but need to continue coming for ongoing surveillance. Support groups is listed there under post-treatment care, but really should be offered from the beginning of treatment and continued care throughout surveillance. This is a manuscript that I did that was published in July of 2022, where this was actually a concept that came out of a symposium with the Bosnian Herzegovinian American Academy of Arts and Sciences, of which I'm a member and typically coordinate their breast symposium and breast cancer discussions. And this was a roundtable that I set up with multiple specialists in breast cancer care from Bosnia and diaspora as well. And we came together to talk about guidelines for breast cancer management that should be upheld in Bosnia and Herzegovina. But again, understanding that there are limitations to some of the things, that if you might not have access to some of these things, we can't expect guidelines to be set up outside of the realm of the access. And so this was actually quite successful and ended up in the publication of this in the BJBMS journal. And this is the first ever published guideline for breast cancer management in Bosnia and Herzegovina. We are currently working with the same group to establish a shorter version of guidelines for the Ministry of Health that can then be distributed along the regional hospitals until such a centralized center can take place. But this was or can be built. But this was a very big undertaking and something I'm incredibly proud of, as the first guidelines for which regional hospitals and physicians can take cue. This received significant, it was very well received in the country and internationally. And this is just showing an article that was done for research outreach, talking about this and how it was established, and how I'm concurrently working with another hospital to try to set up a concept of a central registry to see whether this is something that can be done. In general, from my over 10 years of traveling to Bosnia, what I've tried to do is, through different presentations, meeting with women, meeting with patients, meeting with hospitals, giving talks to providers, giving talks to the media in journals, on radio, on television, to essentially talk about the disease, bring awareness to the fact that this is something that can be talked about. I am very happy to see that and to say that over these 10 years, I've seen a significant greater discussion of this across the board in the country, and people coming up to me on the street, providers reaching out to me to say, "Hey, listen, this is can we talk about this case? This is can we ask your input on this?" And so the discourse has changed over the past 10 years, and I hope that I've had some input in that, with traveling across the country and establishing these connections, establishing this network of physicians in the country and the diaspora who are interested in making changes. And what I've continued to tell everybody is that please continue to keep talking about these things. Please continue, as we've made very slow but significant movement with this and with the creation of these guidelines. And so that I'm hopeful that this work can continue. This is a nice segue to talking very little about the treatment of breast cancer. This is very well known by you, I'm sure. This is a local organization. It's a quote by a local organization in Charlotte, North Carolina, that is a support group that I'm for breast cancer patients that I am very involved with. And they frequently say, until there's a cure, there's care. So, to talk very briefly about treatment of breast cancer and to tie it into some of the things that are available in the Balkans and particularly in Bosnia and Herzegovina. So, when do you get a mammogram? I put that in gold, in pink there. That is the gold standard. That often one of the things that I find when I'm am asked to comment on cases or discuss with providers or patients about breast cancer treatment, that often the first imaging modality is not the mammogram. It's often an MRI or an ultrasound, and the mammogram is reserved at the end of the treatment. And I do want to very strongly point out that the gold standard to start with is a mammogram. You start at 40 every year, earlier if there is a family history, certainly earlier if somebody has a mutation. We all know about the BRCA1 and 2 mutations, and I'm sure everybody knows that there are now up to 9 mutations that will give an increased risk of developing breast cancer. All of them vary between the 9 genes of what that risk is and whether there is a risk for a primary cancer or an additional one after the first one. However, that is something that if a patient has a genetic predisposition, then certainly they should start imaging earlier. Also, there are profiling tests, algorithms that can be done to take into family history, how many biopsies a patient has had, breast density, information about menarche, how many children, all of those things that will calculate a woman's risk for developing breast cancer. It's a lifetime risk. The most common algorithm is called the Hadzikadic-Gusic model. And if that is found to have a greater than 20% lifetime risk of developing breast cancer, then you should start a mammogram earlier. The NCCN guidelines are that in this risk category of an elevated risk, that you should consider MRIs starting at the age of 25 and mammograms at the age of 30, but certainly both of those no later than the age of 40. To go back just a second on why mammogram first, is that often I will see that an MRI is done, for example, and particularly in Bosnia, to bring this back to the discussion at hand, is that in Bosnia, there is actually no modality to perform or no ability to perform a biopsy using an MRI. Therefore, if an abnormality is found on MRI and then subsequently not identified on a mammogram or an ultrasound, there is no ability to perform a biopsy. And so often I see a recommendation to follow up with an MRI in 6 months, which, once again, without the capacity to do a biopsy, that should not be used as the initial test. So I'd like for this to be a very take home message that a mammogram is the first step that one should start with. Supplemental imaging are the ones listed below. So this is where, again, as I mentioned before, I have separated tomosynthesis from mammography because not all centers in Bosnia and Herzegovina have the capacity to do tomosynthesis. So if they do, that would be considered an additional supplemental imaging modality. Ultrasound, MRI, all of those are shown in different ways that you see different things. But that should still be as a supplement to a mammogram. That should be the first test. The types of breast cancer, this could be a multiple hour presentation, which we certainly don't have time for. So in short, breast cancer typically starts in the milk ducts. About 85% of breast cancers comes from a ductal origin, which then the in situ component of that, or of the non-invasive disease, is ductal carcinoma in situ. As that builds up over time, it will eventually turn into an invasive ductal carcinoma. Invasive lobular cancer comes from the milk, the lobules that provide the milk. So while the milk ducts transport the milk to the nipple, the lobules make the milk. The difference between the two of those is that it's the pattern of growth. So milk duct cancers start out like little balls and they will grow into bigger and bigger balls. Lobular cancers will start out like this and they grow tentacle-like. And so they're much harder to see on conventional mammography. The standard of care treatment is the same. There's no study suggesting that lobular cancer should be treated different, but the pattern of growth is something particularly for surgeons to note. The types of breast cancer, then, I thought this was a better way to show is that there are multiple types of breast cancer. We all know that they're denoted by the estrogen progesterone receptors and HER2 protein. So the overwhelming majority of breast cancer is estrogen progesterone positive. And this is a very nice review showing that the proportion of breast cancer subtypes by age. So overwhelmingly across the age groups, the estrogen progesterone positive HER2 non-amplified breast cancer comprises of the majority of breast cancers. However, as you can see there in this slide, that as you go younger, the proportion of the more aggressive breast cancers or the HER2 positive or triple negative breast cancer does increase. Therefore, while in a postmenopausal population, about 11% of breast cancers are triple negative, you can see that that almost doubles in premenopausal women and women under the age of 40. Therefore, this is something to be certainly kept in mind. The treatment is something that, again, could take another 2 hours of a presentation, but I describe this to patients as a triangle approach or a trimodality approach with surgical oncology, medical oncology, and radiation oncology. To take each of those separately, we'll delve into it just a little bit more. However, prior to that, I do want to say that it very clearly not everybody, not all patients need all three of these modalities. Very, very often, patients do need all three of them, but breast cancer is something that is very much tailored to the individual patient, and the discussion is had with the patient where a recommendation is made by a provider such as myself and my other colleagues. However, it is a very clear, distinct discussion with the patient and what option is the best option for the patient, taking into account their history, their family history, their anxiety, how they're thinking about all of this. And then certainly we bring into account the multiple randomized controlled trials that have been done in breast cancer since the 1970s to put some numbers to the discussion to help them make an educated decision. So within the surgical oncology world, there I typically separate the breast and the lymph nodes. From the standpoint of a breast, you have the option of breast conservation therapy, which would be a lumpectomy, compared to a mastectomy. One of the things that we do have to often think about, particularly in Bosnia and Herzegovina, is that they don't always have the capacity for localization of the breast and tumors that are non-palpable. Therefore, a lot of mastectomies are performed partially because of that, because there's no technology to allow for localization, which is an easy fix from a standpoint of access to care and access to things, and where one might want to invest monies, as well as just in general the understanding of a specialty specific surgeons that are following latest evidence-based medicine and research. The lymph nodes, then, as much as possible, we would like to perform a sentinel node biopsy in node negative women versus an axillary dissection, which is removal of all of the lymph nodes and certainly a much more morbid operation. And again, since the 1970s, we've never found that more morbid and more aggressive surgery actually leads to better outcomes. Certainly with an axillary dissection, there's no trial suggesting an improvement in survival with an axillary dissection. Therefore, the trend in breast cancer care in the West has been to de-escalate surgical management, both of the breast and the axilla, and that has been with the advent of significantly better adjuvant therapies such as chemotherapy and radiation therapy. Medical oncology is listed there, and that is, of course, for both with anti-hormone therapy and chemotherapy, depending on the type of breast cancer. Sometimes surgery is performed first, and sometimes chemotherapy or neoadjuvant chemo or hormone therapy is performed first when we're trying to downstage tumors in the breast and the axilla or the axilla so that we can perform less aggressive surgeries. Radiation oncology then typically is the last treatment, and this is either after breast conservation therapy or post-mastectomy therapy, but a multidisciplinary approach is incredibly crucial for breast cancer. This is one of the last slides and advancements in techniques to see with the Halsted mastectomy in the top left, where there was a radical mastectomy, removal of lymph nodes all the way up into the cervical lymph nodes, down to the bottom right picture that you see, which is after neoadjuvant chemotherapy. Very small incision on the breast, very small incision on the lymph nodes, and you can almost not tell that a woman had breast cancer at all, to the improvements in the mastectomy and reconstructive techniques that you see in the middle. Therefore, we have come significantly a long way. Again, lots of support groups that we see and that women should have access to, and that's something that I'm hoping will continue to improve in Bosnia. Certainly, I'm involved with a lot of these support groups that have done a lot for patient awareness and patient access to care. I would love to be able to take any questions, but thank you very much. My contact information will certainly be given to you if needed. I would be happy to take any questions. Thank you for this opportunity. Bye-bye.